Hi, you're about to watch the perioperative session from our Uromigos Live Nashville meeting that we held. We had a great faculty, Axel Bex, Tian Zhang, Dave McDermott, and Sumanta Pal. And they talk about some of the recent ESMO data putting in light of the positive Pembro data, and it's a very entertaining session. And they also talk about what they would do for their next adjuvant trial. I hope you enjoy.
All right, welcome everyone. Welcome to the final session of Uromigos Live 22, where we have an excellent kidney cancer panel. We've saved the best for last in kidney cancer. This is our live stream session. We're going to talk about perioperative therapy. As you know, at ESMO, there was a bunch of trials that came out. It's a lot of new data to talk about, a lot of uncertainty, I think, in the field. So we thought this would be the most appropriate to talk about in this session. Final thanks to our sponsors. Again, thank you for supporting this, what we hope is an innovative meeting. We appreciate your support. And we're going to go on our panel. We'll start with you, Tom. You can introduce yourself.
I'm Tom Powles. I'm an oncologist from London.
Very good. David.
David McDermott, oncologist from Boston.
I'm Axel Bex. I'm a urologic surgeon from the Netherlands, and I work at the Royal Free in London. I think the only urologist on the panel.
I'm sure of it. Yeah. Unless Tian is another skill set.
I don't think so.
Tian.
Tian Zhang, GU medical oncologist in Dallas.
And I'm Sumanta Pal, medical oncologist at the City of Hope in Los Angeles.
And Twitter pollster extraordinary, I would say. We've all learned a lot from Monty about creating Twitter polls this past week. All right, our title got a little cut off there, but this is basically the story of adjuvant therapy. On the upper left, the keynote study, which was positive Pembro data, first presented, I don't remember when, but many months ago, now approved, which was a pretty clean signal, right? This is disease-free survival. This is the updated data. And then at ESMO this year, and Axel reported one of these was Atezo, neo/adjuvant, nivolumab, and ipi/nivo, all pretty flatly negative. You don't even need numbers up there to see that those curves don't split. So Tian, I'll start with you. Were you surprised at the ESMO data, just sort of big picture? Were you surprised that all three of those came in negative? We're going to talk about the individual trials in a second.
Sure. Big picture, absolutely surprised. We were hoping that we would see some signals in the other phase 3 trials. Obviously, large numbers of patients. I think we're still waiting to parse out who is that high-risk population to treat. But certainly surprised at the 3 negative signals.
Yeah. How about you, Axel? You were very involved in at least
Exactly
one of
the same. I mean, we know from atezolizumab that it's not very active in the metastatic setting. So if that were the only trial that was negative, I think as the community would have felt, well, this was to be expected, but completely surprised me with ipi/nivo.
Yeah.
I also had much higher hopes for Prosper, to be honest.
Yeah. David?
Well, I'm good at predicting trials that are going to be negative, since that's
Years of experience.
years of experience.
Decades, maybe.
Yes, so but I think to some extent there's a surprise here in that we knew PD-1 adjuvant was active in melanoma. We knew frontline PD-1 was active in kidney cancer. So translating the melanoma experience to kidney cancer, you would assume these trials would be positive. But we went into these trials without knowing who benefits from PD-1 blockade, and
Fair.
The reason they're negative is probably because we put a bunch of patients on who would never benefit from checkpoint.
Okay. All right, we can talk about it. Tom, final word on the big picture.
I think you can explain what happened, but you can't find one reason to explain what happened. And when there are lots of different bits and pieces going on, it's quite hard to put it all together. The Pembro trial is clearly positive for disease-free survival. It's therefore hard to explain why ipi/nivo wouldn't work. Neoadjuvant therapy's gained a lot of attention in melanoma and in other areas, yet it's not worked here. That's hard to explain too. And then the atezolizumab study, well, the design with the pembrolizumab trial, very, very similar. So it's quite difficult to explain what's happened.
Yeah. Okay. Anything you want to add, Monty?
I mean, I wonder if we can just jump into the first Twitter poll, actually. It might be a good time to just throw it up there.
It took us about 30 seconds. Do you want me...
But to tag onto Tom's point, though, you had done the brilliant discussion at ESMO.
That's sweet of you.
You know, your point that every happy trial is a happy in its own way, but unhappy negative trials are maybe negative in its particular way. I think that was
that's
very
the whole
well
story.
said.
Let's get into the specifics of that. Do you want to do the poll, Monty?
We can hold off.
No, let's look at the poll. Let's look at the poll.
Yeah? Okay.
Let's do the poll.
Let's do it, yeah.
The crowd is clamoring for the poll.
I think so, right?
All right, Mike,
I
take
think
us
so.
through it.
So I basically put up that same slide that Brian had that you saw a second ago, and I basically asked the crowd, based on this data, how is your utilization of adjuvant IO going to change? And what was really interesting here is that the audience was sort of split on less use versus no change in use. But what surprised me is about 20% of patients actually, individuals who responded here, suggested that they actually use more adjuvant IO seeing this. So I don't know if there's any logical explanations for that. I'll pass it back to you, Brian.
Why, anybody in the panel, why would the collective data make people use adjuvant pembro more? Anybody?
Confusion.
Confusion. Press the wrong button. 20% of people.
I mean, maybe it
Happens all
shows
the
a
time.
flaw in our polling system.
What's that?
Tian, I'm just saying our polls clearly have problems with them.
Yeah.
When one tries to pull this together, it's quite difficult.
Right.
But the one, I think the one that people talk about maybe the most is the atezolizumab study because it's a single agent.
Let's go back to the slide.
And it's very similar in many respects to the Pembro trial. And many people feel, is there a difference between PD-1 and PD-L1 therapy in kidney cancer? And that's maybe not a bad place to start. And maybe you want to talk about that.
Well, we've had a couple of atezo trials now, even in metastatic disease, and unfortunately, we haven't seen as clean signals, right, for atezo and Bev than we did for the PD-1 inhibitor-based therapies, and so in the adjuvant space, we were hoping that the EMOTION trial would be positive, and to your point, the similar patient characteristics. Is it the actual agent that's different and the activity is not there? So I still think there's a population that we need to tease out who will benefit from adjuvant treatment. It's just
But you
not
think
in
this
all
is it's a drug effect? Is PD-L1 is less active?
Possibly.
Possibly. Okay.
Yeah, it could be.
Axel,
I mean, there was a, first of all, when we designed the trial, we used the same inclusion criteria. Actually, we were first, and then we saw many of these things being copied from the Keynote team, with the exception that the T3A group for the inclusion in iMotion required grade 3 to 4, so it was actually a higher risk group. And the M1 resected to NED population was actually more than a year after surgery, because you have very good data, at least in the surgical specialties, that if you recur within the first year after surgery, you're more likely to be a rapid progressor, and that would be more towards systemic therapy. But there's one subgroup which showed a little bit of a hazard ratio, which is interesting. So the more than 5% PD-1 expression, or PD-L1 expression on immune-infiltrating tumor-infiltrating immune cells. And that is probably something they could look into, but the group is very small.
Very small,
I don't
very
think
small
that will.
subset. David, what do you think? Why is it negative?
Well, I mean, atezo is active in the metastatic setting. PD-L1 blockade is active. It's probably less active. In EMOTION 150, the response rate to atezo was 25% compared to Keynote 427, where Pembro gets you at 36% or
Right,
whatever.
but let's look at the single agent data though, right? Because you guys are all quoting combination data.
No, I just said
Not-
single agent atezo, 25%, EMOTION 150.
Okay, it's up on the screen.
There you go.
Yeah.
So
David's study.
it's-
You'll notice David authored a lot of these studies. So this is, let me just describe it and then I'm going to have you jump back in.
Okay,
So
fine.
this is David's EMOTION 150 study, which had an atezo monotherapy arm he just described. A single agent avelumab from an early Javelin study. David's Keynote 427 study. And by the way, David, what's your room number at the Thompson Hotel?
427.
There you go. Good job, Courtney. We don't miss a trick here. And then Mike Atkins just reported it in JCO, the HCRN study, which was a little different in that it was Nivo with IPI added at progression or lack of response, but gives us a big data set of Nivo monotherapy. So 2 PD-L1s on the left, 2 PD-1s on the right. Do those numbers look different to you? Does the activity of the left 2 columns look different than the activity of the right 2 columns?
If you're asking me, I would say slightly less active, but you still should have seen more of a signal than we saw in EMOTION
Yeah, I would agree.
110.
Slightly less active based on what?
The response rate in 150 to single agent is 25%.
Okay, 10%
Versus-
less response rate.
Correct.
Okay.
So we should have seen more of a signal than we did.
Okay.
But I think, to me, that's Genentech's problem. It's not necessarily the field's problem. Because I don't think, I think people are extrapolating what we did in VEGF TKI adjuvant therapy to what we're going to do in adjuvant PD-1 therapy. And all of a sudden look at PD-1 as maybe we shouldn't do it because we have 3 negative studies and 1 positive study. I don't think that's going to happen. I don't think people are going to use less pembro because of these 3 negative studies. There may be reasons why they use less, and we can talk about what those are, but it's not because atezo didn't make it.
Okay.
There's just a halo around immune therapy that didn't exist with VEGF TKIs.
Fair.
People are using them in practice like it's in the drinking water. And
In part, thanks to people like yourself.
well, I'm here to talk about the rational application of immune therapy. What I'm saying is we've gotten irrational about our application.
Fair enough. Fair
And
enough.
we can dial it back, but that's going to be up to us. The
Yeah.
industry is not going to dial
Tom,
it
do you
back.
think PD-L1 is less active than PD-1?
So I think PD-L1 therapy has single agent activity.
Yep.
And that's true. So I think it's an active drug. I think when you put it in a randomized phase 3 trial in unselected patients in the adjuvant setting, it's not worked and it doesn't appear active there. I think that it's fair to say with the data we have in bladder cancer as it currently stands, there are more positive PD-1 studies. In fact, there are no positive PD-L1 studies. So it's reasonable to conclude from that that PD-1 is currently outperforming PD-L1.
Yeah, sure.
We need a box.
Throw the box. Nancy, can you hear Matt? It's a pretty long
That's
toss.
oh!
Talk into the top. Yeah.
Hey, Tom J. Rem, I'm a urologist. Really interesting. Our center has been very active in accruing into these trials as well in the community. What about the fact that M1NED is this mystery group? The atezo trial had a huge percentage of M1NED compared to the other trials. I think 17, 18% were true M1NED compared to the pembro trial, which is 4%, 5%. I mean, to me, those are metastatic patients. Those patients may be undertreated with single agent. And frankly, I don't think CT scans, we don't have great staging agents to understand if these patients are really metastatic. So could it just be that this group was just a higher risk group and we undertreated them?
I think when you look at 2 things. When you look at the control arm and the performance of the control arm in the 2 trials at landmarks, the atezo trial and the pembro trial are almost identical. The second issue is when you look at the subset of the pembro trial and you remove the M1NED population, because it's only 6%, it actually doesn't make a huge difference to the hazard ratio. It puts it up by a couple of percentage points. And so, you know, and of course, if atezolizumab was active, you would expect it to be most active in that group because we showed response rate of 25% in the metastatic setting. So you expect it to make a 25%. No, that essentially is progression-free survival. That's the delay. And so if anything, the atezolizumab study should have been more positive. So I think that's a hard explanation.
I disagree slightly because I think if you look, so I agree with the fact that if you take the M1NED population out of Keynote, then it remains still a positive study. If you just look at the, I think the hazard ratio was 0.73 for that group. But if you look at the DFS hazard ratio in Keynote, when they first reported it was 0.29. That's staggering. So it's basically treating patients with an active agent versus not treating them. Yeah. And we know from all these data are retrospective, but recurrences in the first year, they have a very poor prognosis. So I think these patients were subclinically metastatic, but also with a oligoprogressive tendency. And I think that's something we should not underestimate.
Is anybody nervous, as Tom alluded to, about treating M1NED, although they're probably at the highest risk? You're undertreating them. You're potentially undertreating them, and then you're maybe compromising delivery.
I would agree.
David?
For sure. I mean, that was one of the other things we didn't know when we started these trials is how long do you need to give therapy to these patients? We still don't know the answer to that question.
Monty, what do you think?
You know, I'll add some feedback from the YouTube chat, if that's okay. There's a guy named Tony Chuweri. Does anybody know him? No.
How do you spell that?
Yeah. And he says he's from the Northeast, and he points out that this M1NED population that we looked at primarily in the context of the atezo study, greater than 1 year might have just been cured. You know, really limited benefit there. So, you know.
Decreased chance of benefit because those patients had a higher chance of being cured than the Keynote M1 population.
Yep.
Yeah. Okay.
But it's still an active conversation, right? Are these patients truly micrometastatic? And if we waited, 6 more months, would we then put them on IO-IO combinations in the frontline metastatic setting or VEGF-IO combinations in the frontline metastatic setting? I think the point's well taken that there's some patients that have been undertreated a bit. But yours is too, Tom, that if they were a higher population, then the study should have been more positive if atezo was more active.
Let's go now to the PROSPER study. So this was I don't have the scheme up there, but it was a single dose of neoadjuvant nivolumab, then nephrectomy, then 9 months of adjuvant nivolumab versus nephrectomy followed by observation. Did I get that right? Mm-hmm. You see the curves here. This was actually stopped early. You actually see from the abstract, this was not shown at the meeting, that overall survival hazard ratio, if anything, well above 1, although early and wide confidence intervals. And then obviously you see the curves. You see that big drop at the beginning. David, you're a neoadjuvant guy. What happened here?
So I still think neoadjuvant immune therapy is a good idea. The idea to apply it is at least 10 years old. First time I heard this idea was from Chuck Drake, who had data in mice with his lab and Dario Vignali's lab. And when he said this is what we should be doing, because we're treating not so much the tumor, we're treating the immune cells. So you should give the drug, which activates the immune cells when there is more immune cells in the patient. So you should give it before surgery. When he first said that, people thought he was crazy, like.
Which he may be.
Well, meaning people were like,
Defend himself.
this can't be right. This doesn't compute. This doesn't go with how we've been doing adjuvant therapy for decades. So in that context, we tried to launch this trial. And there was a lot of resistance in all directions for that concept. Now, fast forward 10 years later, that concept looks pretty good. Not in kidney cancer, but in other tumors.
So talk about this study. This is the melanoma data just presented. You're a melanoma guy as well.
Right. So this is from ESMO just a few weeks ago. This is a U.S. cooperative group trial, SWOG 1801, and you're looking at essentially neoadjuvant versus adjuvant therapy in melanoma, and you don't have to be a statistician to see those curves. That's a pretty big difference. So if you're asking me what the next step is in the peri-surgical space in kidney cancer, it's do this trial in kidney cancer, do it right, and make sure we get more buy-in, less dropout, less mess, that the PROSPER trial, being a cooperative group trial, was ridden with. This idea, there's no reason why it wouldn't work in kidney cancer. It's working in lung, it's working in bladder.
When you say do it right, what do you mean? Is it, this was more neoadjuvant therapy than a single dose?
Correct.
What else?
But also, ideally, it's a sponsored trial so that the investigators are bought into the concept of completing the regimen, as opposed to patients dropping out and falling off treatment. When you start getting into the PROSPER data, and this will come out in future meetings, there's a lot of dropout. There's not everyone got that therapy, which is understandable. It was a bold idea, but not everyone was bought into the concept. Not all the surgeons were bought in. People were diving off the study at various time points, all of which is understandable then, but not now. It's a good idea. It should work in kidney cancer. Maybe there'll be more buy-in from both patient and clinician.
You think because of the melanoma data, because of general enthusiasm, there won't be that heading for people won't drop out as much. They'll be more committed because of these data made on the screen.
Right, and if you're asking for what the next advance is, by giving the therapy, the only difference between those arms is giving it pre-surgery versus not.
Right.
And there's an advance there.
If I may, there's a couple of differences between the melanoma trial and PROSPER. So one, they're, I think, a bit more careful in the patient that they selected. And two, they have 9 months, or 3 months of treatment instead of 1 month of treatment prior to surgery. So there are nuances here, and I think that certainly we see the activity in melanoma. Kidney cancer is a very immunogenic tumor. We would love to mirror that in kidney cancer. So if there would be an opportunity for such a trial, that would be, I think, I agree.
I mean, talking about the length of pre-treatment, I think it's actually quite interesting. We did this neoadjuvant trial with avelumab and axitinib for 3 months, and now we have a sequel in Amsterdam, which is called NESCIO, where we treat patients for 6 weeks with ipi-nivo, nivolumab, and nivo-mono. And we recently had a patient who had a complete response after 6 weeks of pre-treatment. So I think we do not necessarily need 3 months. And in my point of view, you see very little happening with nivo-mono. And I think that might be one of the reasons. I think if you design a neoadjuvant study, it might be better to have a short pre-treatment with a combination and then have a maintenance following.
Yeah,
something
more
like
intense
salvage.
treatment,
Yeah.
but
just
neoadjuvant. David?
Going back to what Tian was saying, which I agree with, we've learned a lot since this trial the PROSPER trial was initiated. PROSPER originally started out as 2 doses before surgery, for example.
Sounds like a
But
good idea.
right now, everyone thinks that's a great idea, but the surgeons didn't want to wait. You know what I'm saying? They're not all as relaxed as Dr. Bex is as far as going to the OR. Patients didn't want to wait. It was also a question was placebo trial versus not, observation. This would be active therapy versus active therapy. Patients would buy in, clinicians would buy in. We could avoid treating some of those early patients, those non-clear cell patients, whatever we could learn and do better.
Let's go questions to Dan, then Monty's going to put up a poll.
Great, yeah, so David, this is a higher risk population, right? I'm looking at that adjuvant arm, and in 18 months, already half the patients have relapsed. So is that part of our problem? Are we still not selecting a high enough risk kidney cancer population? Are there other factors we should be using to do a better job of that?
Right, I completely agree. I think we went based on the clinical staging criteria. It's not clear to me that that is relevant or as relevant to IO therapies as it would be with no therapy. So for example, a tumor that might be enormous in kidney cancer but not metastatic, I mean, to me, that's likely a relatively low-grade tumor, or likely a VEGF HIF-driven tumor, not a aggressive, high-grade PD-L1 expressing tumor that would be metastatic at a much smaller size. So in my mind, size is less important than biology, to your point. And we went into all of these studies without fully understanding that. I just don't want the field to say, we shouldn't learn from this. We need to learn and do it better the next time.
Yeah.
Can I,
Thomas.
before we go to Mon, can I list the problems with PROSPER? Because,
Please.
Yeah, so PROSPER was an open label trial. There was a randomization, but one of the arms forced to have a biopsy. Now that's really complicated. At my institution, if you have to do a biopsy, it's going to delay you by 4 or 5 weeks. Because by the time you've planned it, you've got it, the patient's had it, they've gone home, you've got the pathology result, and you've spoken to them, and you've booked the slot on the day unit, that's a 6 or 7 week process. That's a problem. It's a big imbalance in the 2 arms, and that's important. The second issue is there is a super low risk population in that trial. They included lots of patients. It's an investigator-initiated trial. We've all done it. Investigator-initiated trials, hard to recruit to, so you open up the inclusion criteria a bit to let some of the good risk patients in. The problem with that is there are lots of T1s and T2s. That's a big issue. Number 3, they had their assessment of progression-free survival included if you didn't have surgery, that was an event. That's a big problem.
But that's pretty standard for many trials.
No, it's not.
It should be standard for this trial. Look at the curve. It goes like this.
But it should be censored. You can't say, so the reason you have progression-free survival is it's supposed to be a surrogate of overall survival. So let's just go through a patient right now, David. Patient comes in.
I sat them together for a reason.
Let's have a patient. They come in. They have nivolumab. They say, a bit of a delay, a bit of toxicity. I want a scan before I have my surgery. They have a scan. There's no progression. The cancer's a bit smaller. They say, I don't have the surgery. That patient is not a surrogate for a death. That's not a surrogate for overall survival, whether you like it or not, and therefore...
In fairness, we don't know how many patients
we
that
don't know,
applied to.
but there are 15% of the patients. There were more patients who had events in that respect than actually went on to have real progression events. So more than 50%. So when you look at the story together, that is a big flaw. Now, there are other flaws in the trial design as well.
You don't have to give your whole ESMO presentation.
Yeah, I'm not going to. But,
we heard it.
But we
It was
just,
great. Really
but we just need to be. Now, look, it's a great study. It's a huge investigator-initiated randomized trial.
Yes.
It's an enormous undertaking. It's much better than any of the neoadjuvant trials I've ever done. I've tried 3 or 4 of them. They've never been as good as this. It highlights the difficulty of doing this trial. And so I think the cooperative group did an amazing job, but I just feel that it is premature to let this story go.
Yeah, what I find
So
very...
you're agreeing with me, is what you're saying?
Well, it doesn't sound like it, David.
No, I said we should do this again better. And you're
Yes.
saying it's premature to let this story
no,
go.
we
With
are
an
agreeing.
accent.
We're
Okay,
disagreeing.
Monty, why don't you pull up the poll?
Yeah.
And then we'll go a question from Ben.
I think you agree.
Yeah,
with
you
me.
can go ahead and share my screen
Oh yeah,
here
just do
now.
computer up.
Yeah. So, we put up this poll across each one of the studies. And basically, what you see in the top right-hand over there sort of mirrors this dialogue that we've had around PROSPER. So you can see that, a couple of folks, maybe a fifth of the audience thinks that neoadjuvant therapy really just doesn't stand a chance based on principle in RCC. Most think that the death of this study was low-risk patients included. And then the observation control is also cited as a reason. And I'll use this opportunity just to highlight some of the dialogue on YouTube as well. So Tony Chiweri hits on many of the same notes as Tom did. Sandy Srinivas from Stanford actually brings up something interesting. She says that she feels it's actually going to take 9 to 12 months of neoadjuvant therapy to really evoke a reasonable response.
What do you think of that, David?
There's no data to support that statement. I mean, I love Sandy, but no, but seriously, the first trial of what became Nevo was how many doses? One dose. You could only get a second dose if you responded to the first dose. We have no idea how much PD-1 you need to evoke an immune response.
And it's probably different for different patients.
Absolutely, and there's some patients who need chronic therapy, and there's some patients who could get away with just a few doses,
Okay,
as I
back to
think
mine.
Axel was.
So David, there's a lot of folks sort of pushing back on that on YouTube. Krithi Mittal,
Without
for
evidence.
instance, also suggests that, we probably need a longer duration of therapy. I mean, I wonder if we can just kind of go down the row here and see how long is reasonable for a neoadjuvant window for an RCC study.
Reasonable meaning practical or enough to give you an immune response, or both?
But maybe both, right?
Sweet
'Cause-
spot of
right,
both.
right.
Okay, Tian, why don't you start?
I think around 3 months. That's when my patients are having their best responses. And then
Okay.
right around 6 to 9 months, I'm starting to see progression if I'm giving
3
perioperative.
months.
What gave me a little bit of a headache was that in neo-AVAX, when you did spatial transcriptomics, you saw some areas where there are responses and others where there's no response at all. So if you go longer than 3 months, you're actually delaying potentially curative therapy.
Yeah.
I would really go for shorter, and I think all you need is the stimulation of the immune
Shorter,
so
as
why am I
in,
going for
give us a time or number of doses.
I would go for 6 weeks.
6 weeks, okay. About 12 weeks, 6 weeks.
6 weeks sounds good to me.
Okay.
I'm nervous about 6 weeks because it's doing the same experiment a second time. And this is a very negative trial. I know there are flaws in it, but we're doing almost exactly the same thing twice. I think, unless we think it's so flawed, because the curves are on top of each other, it's not even a near miss. And so I think we should ask a different question, and therefore I'm inclined to agree with Tian and say, let's go for a longer period this time.
But something happened in Prosper. I mean, if you would go
something
back
certainly
the
happened.
slide.
Go
is-
back, put the slides back up.
So the dropout in the observation arm is really unusual.
Yeah.
In a population that are basically surgical candidates, that you already lose 10 to 12%, I don't know where that drops down to, of your population that does not have surgery. Neoadjuvantly, you could argue, well, they either have responses or they have toxicity, there's always a reason. But 10 to 12% of a surgical population that doesn't make it to surgery, I don't get it.
Right.
It's a big drop, we agree.
Right, but
David.
David. Called on me first. The explanation, Axel hits on the right thing, right? He hits on the right thing, and that we need to explain, we need to answer that. We need a full, what's it called? Consort diagram, which we don't have yet. Which
We don't have a full one. I have a partial one, but go ahead while you're
okay,
talking.
but the point is, the details will.
Details are important. Fair.
Yes, and until you see all the details, I have some insight into some of the details. Can't talk about it. Go to GUASCO. There'll be more data.
And, ooh, a
30 patients,
teaser from
right?
David.
To your point, 30 patients.
Monty, did you want to pull something up, or you want to go back to the poll? Or?
I was just going to add some comments from
Sure,
YouTube,
sure.
actually. So just on this same topic of Prosper, and maybe this is relevant to some of the other studies. This guy, Tony Chiweri, again, if anybody knows him, definitely, let me, he's quite vocal on this YouTube chat, says that, perhaps one of the other issues was the inclusion of non-clear cell patients in Prosper. I mean, what do you guys think of that? Was that a contributor at all?
I mean, I think to Tom's point, it's a bunch of little things, right? It's a little of this, it's a little of that. There weren't that many. I don't remember the numbers, right? It was single digits for sure.
No, it was high.
Was it high?
Yeah, it was. I can't remember. I think it's 15 or 20%. It wasn't.
Oh, no,
It wasn't
high.
5%.
Somebody find out. It wasn't 15 or 20.
But could that have made a difference, Tom?
Yeah, every time you put, 15% the surgery, 10% non-clear cell, 5% this, 2% that. Eventually you end up with a big negative trial. The concern I have, Axel's point, is if we say we're going to do exactly the same experiment a second time, it means we're essentially saying we're just disregarding this completely.
No one said we're doing the exact experiment.
But it's 6 weeks. You said 6 weeks.
Combination therapy.
Well, he's got a different.
Okay, well now we're changing our mind. This is impossible.
But the other thing to point out is we're going to learn a lot more about what happened to these patients. We're also hopefully going to learn information from the biopsy and then the nephrectomy, be able to compare in the patients who got paired specimens. What do we see? Do we see changes in the tumor that give us an idea of were we creating immune responses or not?
Yeah.
There's going to be a lot you can still learn.
I think that's going to be very
from this.
challenging because of sample size of the biopsy.
Exactly.
But
that's
the
what we saw in
nephrectomy,
neo-AVAX as well.
nephrectomies are like this big, though.
No, I know, but I'm saying biopsies are like this big.
I
It didn't match, unfortunately.
Okay. We'll see. I think just stay tuned is what I would say. Stay tuned.
Can I just push a little further there, though? So Tony actually mentions that it's 21% of folks that were non-clear cell, in this context, and so it's a pretty sizable proportion, right? And so with that in mind, right? With that in mind, what do we do for our non-clear cell patients? Do we forever exclude them from adjuvant trials?
There's a study called Rampart, and Rampart's an ongoing study. It's essentially durvalumab, tremelimumab, durvalumab, best supported care 3-arm. There's questions about what you do. Is it ethical to recruit to those trials? We can ask that question today, but one of the subpopulations of that study is non-clear cell, and I think that's one of the really valuable questions that study can answer.
So we have to find what's biologically relevant for each of those subtypes, right? Non-clear cell is actually many subtypes, and we have to actually see what is actually active for those patients. So in papillary, could it be cabo adjuvantly, right? Is that the right treatment? So things that we're learning in the metastatic space, we have to extrapolate. It may not be a single agent PD-1 for all the non-clear cell types.
We're going to move on to the next study. Adjuvant Ipi-Nivo, Checkmate 914, again, negative study. David, you're an Ipi kind of guy. You're a Ipi-Nivo kind of guy. What happened here?
Okay, so if you had asked me what I would have predicted would happen in this study a year ago,
Okay, tell us what you
I would have said Ipi won't add anything to Nivo. Not because I'm some sort of clairvoyant individual, but because we did this study in melanoma of Nivo versus Ipi-Nivo, and the curves are like this.
Okay.
So I'm not surprised that Ipi is not adding to Nivo in kidney cancer. The problem is not that Ipi, although we can talk about the problems Ipi may have contributed, it's that the combo doesn't add much, which means it either implies that Nivo is not doing much here, or by adding Ipi, you're creating a toxicity issue that's either limiting therapy or adding steroids, both of which are probably not good to an ongoing immune response. But you essentially have to explain how Nivo performed in this trial, you essentially have to invoke the concept that Ipi was harmful in this setting, which may be a stretch.
Fair enough. Other thoughts, other comments on why it was negative?
I mean, this is the hardest to explain.
Yeah.
So you can say there was only 6 months of therapy, and that might be crucial. You can say that the addition of Ipi to Nivo made the toxicity so great that you are unable to give the combination. But I think most people in the audience would accept that the PD-1 inhibitor, nivolumab, should have behaved quite similarly to the PD-1 inhibitor, pembrolizumab. Now, there might be different activities, and Pembro may indeed be the most active drug in this disease. We don't know that yet because we haven't seen the single arm from this trial, and there is a single arm from this trial, and that's going to turn out to be really important, because if that single arm is also struggling, then we're going to be quite confused about where we are. So this is, for me, I can explain PROSPER. I was okay with atezolizumab 010, but I find the Ipi-Nivo one particularly challenging to explain.
Yeah. Another potential...
Just wanted to put this slide up that talks about toxicity, I think you both alluded to. Oh, sorry. Actually, Ben first. We'll do a question. Sorry, I forgot.
Well, I was just thinking more in the perioperative space, back in the neoadjuvant setting. Sorry, I'm Ben from Sarah Cannon here, embedded in the community at Tennessee Oncology. If you're talking about adding duration of immune therapy, you're also talking about when you borrow from the M1 space, right? There is a dropout rate where patients have primary progressive disease, and there is a balance there of taking a patient who is curative and pushing them to non-curative potentially if you delay the nephrectomy. So what I would wonder is, and I think it was alluded to on the panel, is that combination with TKIO up front followed by adjuvant IO. I just didn't hear if anybody else agreed or disagreed specifically with that comment, because to me it makes like a biological rationale when you're keeping somebody away from that kind of progression if you're going to extend immune therapy for too many months.
IO, TKO, neoadjuvant, followed by adjuvant IO.
Correct.
Anybody want to comment on that?
I mean, Axel's well placed to do that. His neoadjuvant trial didn't show a lot more activity from a response rate than single agent Axi.
Yeah.
Yeah, but I do believe, and that's actually quite interesting. In the beginning, I thought, so we work at the NKI a lot together with the melanoma oncologists, and they actually work by the International Neoadjuvant Melanoma Consortium. So they are much more into pathological responses. And interestingly, the pathological response we see in neo-AVAX in the avelumab axitinib trial is completely unrelated with your resist response. It's all over the place. So I do think that immunotherapy initiates pathological responses, and the downsizing effect we see is partly due to axitinib. And that's also what we saw in the neoadjuvant study that Jose Caram did at the MD Anderson.
Clearly there were tox issues as shown here. I think somebody alluded to high-dose steroid use. So we know it's a toxic regimen, right? Perhaps even more so in the adjuvant setting, that limited therapy. Mani, do you want to pull up the poll relative to this?
Yeah, I'm going to pull that up in
get
just
the computer up.
1 second because Cora Sternberg, who actually I'll do a Uromigos plug at a Uromigos Live meeting, who has a brilliant Legends in Oncology podcast with you guys, suggests that toxicity is one of the issues with Nivo-Ipi, as we've already discussed, but length of therapy as well. That's 6 months of treatment. And actually, Sandy Srinivas from Stanford suggests the same. Anybody here on the panel think that perhaps with a longer stretch of nivolumab maintenance, things might have been different?
I see David about to heavy sigh.
No,
over
I'm
there.
not. I mean, I think the short answer is, and I was a little abrupt earlier with Sandy's question. So I apologize. But I guess the short answer is we don't know how much PD-1 you have to give in any scenario for any cancer type. And as a field, we probably should try to figure that out because we've given PD-1 to so many patients. So there are some who probably need indefinite. We learned that on the original trials of these agents because you had to stop at 2 years. And some patients stayed in response, like the melanoma patients, a lot of other patients, lung, bladder, kidney. And some of those patients who progressed after stopping actually could be salvaged. So we need to understand who those patients are. And without understanding that, we're setting ourselves up for trials like this.
Fair enough.
Give us negative results.
Anybody else want to comment on duration? It's hard for me to believe 6 more months of Nivo would have made this a positive study, but
Yeah, I'm very curious to see the Nivo alone cohort.
yeah, I
when
think
once
it's
it
pretty
becomes
small. I don't know if anybody knows the size of it, but
Yeah, the only thing
Dan's got the box. and
Just
then
real
go
quick,
to
real quick. So if you go back to the Kaplan-Meier curve, you had probably the best placebo result here with 2 years at 74% disease-free survival. Is that the issue here? When again, not picking the really the right patients for these kind of studies.
I want to make a comment about this as well, because I think that the placebo arm is at the level of the effectivity arm in the keynote. And what you alluded to before, I think we haven't yet figured out, for example, the INDC score, that largely coincides with this genetic risk profile, which still has to be validated or is being validated, but we don't have anything like this for TNM. We don't know whether the higher TNM stages are actually more responsive to IO.
I think to David's point earlier, our clinical way of stratifying patients in this setting probably has nothing to do with their response to immune therapy, right? Is that?
Biology is more important than stage. It's more important than histology.
We just don't know how to measure it. Thomas.
I was a little bit frustrated that there was no survival data shown here. This is a negative trial. The primary endpoint's read out. It's never going to be a positive trial. So it's not like we're waiting for an event that's in the future going to be different. And I don't see the disadvantage of showing survival data. And one of the things that I saw at ESMO in different areas is we saw we didn't see the survival curve for Prosper either. I'm told that the hazard ratio, in the abstract, the hazard ratio for survival was 1.46. And that didn't then, the hazard ratio 1.46 in the abstract then wasn't in the presentation. That makes me, because that sort of hazard ratio, you look at, very few events, but you think that should be there. They've done it and it's a survival, it should be there. And then here again, this is a negative trial. You can show it. You can say, okay, it's underpowered, but this is the curve for what it's worth. But I'm nervous that in the kidney cancer community, we really are getting into the habit of doing analyses and not showing them, and particularly for survival. And I think we as a group need to perhaps, and I'm maybe part of the problem, but we as a group need to make sure that we do, when we do show survival signals when we know they've been seen. And it's, often people say, well, we haven't finished the trial or it's not unblinded yet or whatever. But actually in the adjuvant setting, for example, you've had your year of therapy, the minimum follow 16 months, everyone's been through that, and no one's going to volunteer to die in one or the arm or the other. So it's actually okay to show these survival signals, even if they're immature.
I agree.
So that was a nice speech, and we'll have to remember it in a few minutes.
Well, we're recording.
Remember
the whole
that,
thing,
everyone. It's like Macbeth.
I'll say, aren't you the guy who...
Here we go.
Here we go.
So
Here we
just
go.
to comment about the 914 data. So I think when we talk about risk, this trial excluded the M1 NEDs. it included the low-grade T2 patients, which is why I think the control arm is performing a lot better, and maybe these people are going to be cured irrespective of therapy. So I think that's weighing in, and I think with regards to duration, people got, they were intended to receive the 4 doses of IPI on that 6-week schedule, not the 3-week schedule, which is very different than what we do in the metastatic setting. So I don't think we can chalk it all up to duration of therapy.
Agreed. Mani, you want to pull up the poll?
Yeah, let's do it. Let's do it.
Chatter.
And while that's coming up here, I'll just point out that Sandy Srinivasa says she is fine with your comments, Dave, and she loves wine and
she'll never speak
chocolates.
to you again.
And I'll just point out the result of what we got ahead of the meeting with actually a pretty robust response to our polls, I might say. So if you look to the bottom right over here, these are reasons that we posited for perhaps 914 being negative. So you can see 1/5 of folks thought that adjuvant IPI itself was not active in this setting. 1/5 suggested that the trial needs more time to mature. I'd be curious to run thoughts on that. And then more than half suggested it's this rationale of excess toxicity. And Mike Stahler points out, our good friend who's a surgeon out in Germany, we all know him very well, suggests that there were 5 deaths on account of toxicity in the adjuvant Nivo study. To your point of looking at overall survival, is that an issue? Does it call out Tom's point of looking at these OS curves, perhaps?
Who are you addressing that to?
What's to you, I think, David?
Just this general direction.
I think Tom was saying we need to see survival, and maybe that there could be a signal there, even if there's not in this, right?
Yeah.
Right, so in melanoma, not to talk too much about melanoma, we don't see OS in any of the trials, and that has caused people in the field to pull back from the application of immune checkpoint blockade, even in settings where it's approved. So for example, stage 3A melanoma, which is most of the melanoma we see in clinic, we often don't reflexively give immune therapy, in part because of what Monty's talking about, is occasionally we'll have a patient who's a train wreck or a death with immune checkpoint blockade, and that is completely unacceptable, and it leaves a mark. So at some point you say, do I want to keep doing this? And they're going to be, in some ways, this data is more reflective of what you'd see in practice than what we see in Pembro, which is a very clear safety profile, but it's probably unrealistically clear for what's going to happen in the community when we start giving these drugs.
In the Pembro trial, there is a trend towards overall survival. The hazard ratio is 0.53. It's not significant, but it is a trend towards survival with the follow-up we currently have. And that's encouraging. And if that trend continues, then that will be a significant result. And when you see patients and have a conversation with them, because they're not going to be able to make a decision in 2 years' time, it's today, you have to have adjuvant therapy in a short window, you can say to them, there's uncertainty around survival. We're clear it's going to delay the time to your cancer coming back, and there's a trend towards survival with underlying toxicity. And that's encouraging, and that's quite a positive thing to say. One of the issues that I had with nivolumab yesterday with the bladder cancers, we haven't seen that survival curve yet. That makes that conversation, in my opinion, more complicated. It would have been easy to show the survival curve here, and if the curves are indeed on top of each other, or in Prosper, I suspect the wrong way around, that's even more evidence that you might say, irrespective of the PFS analysis from Prosper, if the curves are the wrong way around, you can't, all those issues I said about how you measure PFS and all the bits and pieces, it's difficult for them to have influence on OS. And if OS is miles away, you can say, well, this approach clearly is not working. So I think there is a lot to learn, even from early OS signals, without making significance from them.
Agreed. If we go back to the slides, this is a table that looks at David, you brought this up, maybe IPI is detracting in this setting, right? So this is single agent Nivo data, again, from HCRN, from Titan, which was Oliver Grimshaw, I think updated at ESMO this year. The original Checkmate data, which is obviously the most mature, there was a UK study called PRISM, which gave modified IPI dosing. You see in that second to last column, Q12 weeks of IPI. It was a randomized phase 2. And then the control arm of Cosmic is obviously a big IPI-Nivo data set. And I know there's tons of imperfections in these tables. You don't need to point them out. Everybody on Twitter has pointed them out to me. Thank you. But they're really just, if we look at single agent data and combo data, and this gets to a bigger metastatic question that we can come to in our second section. Do you think IPI is adding or detracting to Nivo, David McDermott?
I think based on the data we have now, it's adding. It may not be adding a lot. but I think it's adding in two places. So it's adding in the primary PD rate, which is the major weakness of pure IO regimens compared to VEGF PD-1, is those early progressors who will die if they don't get VEGF up front. So, but in CTLA-4 combos, you see a little bit less primary PD. It's adding in the CR rate, which in those deep responses like CRs and very good PRs tend to be those patients who are out at the tail of the curve and those who can come off therapy and live in remission. So I think it's adding, but if you're asking me what I'm expecting from the 8Y8 trial, which will address this question.
I wasn't, but go ahead.
I'm nervous about that trial, and we'll see. Hopefully we'll get those results.
Because it adds in ways that may not be obvious on traditional endpoints.
Absolutely.
Early endpoints.
Right.
Yes.
So it's, once again, if we continue to do IO studies with targeted therapy endpoints, we're going to see confusing results. You need to look at things like landmark progression-free survival, for example, as opposed to median progression-free survival.
Agreed. Tian,
Now,
UT Southwest use a lot of Ipi-Nivo, right?
We do. We're big prescribers. But of the 214 data, what's really impressive is that 5-year progression-free survival curve. There's about a third of patients that don't progress, right? And those are the patients that we're doing the most benefit. And also the treatment-free survival data that's David and Meredith have put through. I mean, I think it's really important the time that patients can have off of treatment. And so those endpoints are not captured in this table.
Yeah.
Can I jump in?
Please.
So I think
It's your meeting.
I'm sure it is. But so the first thing is the progression-free survival curve of CheckMate 214 is a lot more complicated than it looks. That 30% at landmark only represents 10% of patients. So 500 or 100% of patients start on the trial. At that PFS at 5 years that we talk about, there are only 10% of patients get there. So there's censoring of 2/3 of the patients beforehand. If, for example, you didn't get the 4 cycles of Ipi-Nivo, you only got 2, you're censored. There are lots of early censoring. And so, although it says it's 30%, it's only 10% of patients. And that creates a huge amount of uncertainty. Okay, that's really important, number one. No, let me keep going. Let me keep going. So that curve is a correct progression-free survival curve, but there is really heavy censoring, and we're not talking about that enough. That's an important point. Number 2, if I may. Number 2, this treatment-free interval is also complicated, because it's not like patients were going along happily saying, okay, I'll stop my drugs, it's great. No, they have to get into toxicity, they've got to have problems, they can no longer have the drug. And once you've got into those problems with the drug, you can then stop. You have to crash the car. There are no brakes. You have to crash the car before you get out of it. And the issue with that is there's going to be a bias associated with that, because we know that immune therapy tends to work a bit better in those patients who get adverse events. So essentially, you're selecting out the winners. And so this progression-free, this treatment-free survival piece is not pure treatment survival in a benevolent, you'll stop the drug and see what happens. It's you've got grade 3 or 4 transaminitis, we have to stop the drugs, and those patients do relatively well. So 2 problems with the CheckMate 214 study. Now, don't get me wrong, it's a great trial. The landmark OS analysis is fantastic.
You've already done the damage. I wouldn't bother with it. David.
Axel wants to speak.
Axel first, then we'll do David's response.
So I would very much support your view, David, because I think from when we have a couple of patients, or we have a series about those ones who are treated with a primary tumor in place. And if you look at those ones who have been treated with Nivo and those ones with Ipi-Nivo, there are much more pathological responses in there. And I think it's just a small group, but where you can achieve deep responses with a combination. And that's also based on the adapter data that with Nivo mono, for example. The theories are that if you do have a clonal T-cell response in your primary, and you happen to have a very clonal reaction to a neoantigen, then you're in for a win when you give it. And I think that you need CTLA-4 to stimulate that.
So David, I'm going to give you the last response on this. No swear words, don't insult anybody, and don't hit Tom. Say your piece about TFS and what Tom said about the censoring. And then we're going to move on to the future of adjuvant therapy.
Okay, well, what I would start by saying is Axel should be at more of these Uromigos podcasts.
We'd love to have him.
I'm only joking a little bit, but he's a surgeon, right? And this is a medical oncologist, a GU medical oncologist, who spends most of his time taking care of what he thinks of as incurable cancers, whereas the surgeon is only concerned with curing the patient. Anything short of curing the patient is a failure. right? You don't pat yourself on the back if you didn't get the whole tumor. If you get the whole tumor, you're like, we got it all. Thumbs up. And to me, we as medical oncologists need to move toward thinking in potentially curable cancers like kidney cancer, more like surgeons and less like GU medical oncologists. So kidney cancer can certainly be put, we all know this, everyone in the room knows this now. You didn't know this 20 years ago, but you know it now. You have patients who are in remission after getting immune therapy for metastatic disease.
Yes.
Right? So to me, in the hierarchy of endpoints, remission is most important because it's those patients in remission that will be eventually potentially cured. I'm not sure all PD-1 responders are cured, but they're certainly in remission, right? And TFS is a way of measuring, at least in part, remissions for the entire cohort, not just the winners. It's not about showing that ipi/nivo is better. It's about let's take the whole cohort of patients and measure the pluses and the minuses of immune therapy. Because we're not just talking about treatment-free survival alone, we're talking about treatment-free survival with and without toxicity. So to your concern about crashing the car, whatever that means, if you were crashing the car with ipi/nivo, that time of treatment-free survival would be spent mostly with toxicity, and it is not, okay? It's not. So there's more treatment-free survival in the ipi/nivo arm versus the VEGF arm. What we need to do is a head-to-head comparison of IO versus IO-VEGF, and one of the trade-offs with IO-VEGF is you spend most of your time alive on drug. And then you put it up to the patient. So you say to a patient, you know, survival is similar with these regimens, but you might spend twice as much time off drug. And some patients might be willing to go through the tox for that trade-off. But it's about trade-offs. And it's an endpoint that can be measured before treatment or can be explained before treatment, so it helps with clinical decision making. It's not just about...
I don't think we're going to solve this today, I'm feeling.
I'm not
just
clear.
getting revved up. I didn't even get to the PFS thing, which is the...
Okay, give me 30 seconds on
PFS.
Tom's PFS. Again, no swearing.
Go, Dave, go.
The only person ever to swear on a Uromigos podcast, David Jones. 200 podcasts. 200. Anyway, don't worry about that. 30 seconds.
There's a ton of patients on those curves at the end. You're talking about the patients who haven't been censored as if censoring is somehow like a bad thing. These are people who are out there. They're alive. They're more than you are estimating. That are progression-free. They're just censored because they're administratively censored based on when they did the data cut.
Yeah, no, I accept that, but when you get to the 5-year time point, they're not there on the PFS curve. They may be there on the OS curve.
They are there.
No, they're on the early part of the curve, not the late part of the curve. They're not the late part of the curve. I mean, there is the curve.
They're not at risk. we haven't seen them.
No, they're on the OS curve. They're no longer on the PFS curve.
That's right.
I don't think we're going to settle the censoring issue, but I think there is a lot of censoring, and it might actually be underestimating that plateau,
Absolutely.
right?
It could be.
Right.
It could be.
And
But
TFS,
it's not just a bad
because
thing.
TFS is a hard endpoint. You're either on treatment or you're not. In some ways, it's a better way of measuring the impact of an immune therapy than PFS is. Because PFS is a dodgy endpoint.
David, okay, I'll accept that. I'll accept that bit. Does that make
All right,
sense?
let's move on. I think this is our last
I'm
slide
ready to
before we
go.
go to the future. So this is just a summary slide on Keynote. It's the updated data. Anybody want to comment? We saw what the Twitter poll said about more or less use or the same. Anybody who gives this in practice want to comment on whether it's impacting your practice? All the negative data we talked about and all the caveats in these data. Tian, you giving more or less the same?
I mean, we have conversations with patients, right? These trials certainly show that if you're going to use an adjuvant treatment, you're going to use adjuvant pembrolizumab. But the person that you're going to use it in may differ. And the patient who sits in front of us to tell us, you know, I'm accepting every 3-week visits, I'm accepting IO toxicity to potentially delay as much as I can, as much as we know in 2022, I want everything you have. That's a patient that, you know, should be treated and is at high enough risk. There's another patient that comes in and says, you know, doc, I will accept that I will, you know, there's a 2/3 in the control cohort that don't progress by 2 years. I'm going to wait until I absolutely...
But are those conversations different now with 3 negative trials? It's always trade-off and benefit risk.
Yeah, and I
they
will
different
say,
from
you
your
know,
perspective?
but the patient who is going, it's very binary for the patient in front of us, right? They're either going to recur or they're not.
Yep.
And so I cannot look in the glass ball and predict that for them. So I can only help them make that decision of, is, you know, a year of
I understand. Are you thinking about it any differently now with 3 negative trials or not?
I'm still having this conversation about pembrolizumab.
All right, so Axel, what do you think?
So we just updated the EAU guidelines, and we also have patient representatives on the panel. And they actually suggested, and we took this over as a recommendation, that patients are informed about that there are other trials out there that are negative, but for them it doesn't necessarily change the way it will be given, but the information should be out there. So
Okay.
it's a shared
David?
decision making.
Change your approach, yes or no?
No.
No for Axel.
sorry.
David?
No, the only thing that would change my approach is if that OS signal goes away, and it's possible that it might. And if it does, we'll get into a similar discussion as we do in melanoma, which about risk and risk reduction. I mean, Katie Beckerman had a great slide, which I think she might have borrowed partially from you, about risk reduction. We need to understand what are the risks based on that person's stage and how much is going to be reduced. Because when you have that conversation about when they realize that their risk of recurrence may be only 15% and the drug only brings it down to 10%, whatever it is, people think of it differently. That's a hard conversation for me to have, but that is, I think, more
Agreed.
meaningful
Thomas,
way.
yes or no?
Dampened enthusiasm in the field, undoubtedly. I think there has to be a conversation with the patients around the fact that you haven't got, before it was easy, there's a positive trial with this ARIS signal, we've got lots of other trials coming through, really exciting. I think now the conversation is, this is the standalone drug that seems to have been successful, others for various reasons haven't, we don't quite know why, and we haven't seen overall survival yet. So I think it's more complicated.
Awesome. Yeah, sure, Tom. Throw him the mic. Rena.
Oh, no.
Do all the flugatis.
Trying to bounce it off Nick's head again.
I would just, the one thing I would say is for the people up here who are designing the trials going forward is there is so much heterogeneity in this T3 group of patients. And as a surgeon, it's frustrating because to me, there are 4 levels of T3A. It's really not that substratified in any guidelines, but there's perinephric fat, renal sinus fat, small vessel invasion, large vessel invasion. Perinephric fat, especially in a small primary tumor, carries a minimal risk of recurrence. I mean, these are 8%, 10%, and your large vessel renal vein patients who are T3A, I mean, could be 50, 60% patients who are going to recur. So I understand the comment about biology trumping stage, and I think it's great. I hope something that comes out of all this is that these stages and some of these issues in the guidelines are addressed, because it really, one T3A patient is definitely not like all the others. So I'm hoping we can start throwing out some of these really low-risk T3A patients.
Yeah, I totally agree, Tom. Thanks for your comment. All right, we're going to move on. The last part of the live stream is where we're going from here in adjuvant therapy. You each submitted a slide of what you would want to do for the next adjuvant trial. When your slide comes up, you'll discuss. There is going to be a prize for the winner. We're going to vote at the end. And my patient, Michael, who's here in the room, made a golden kidney. All right, it's a 3D printer. 3D printer, Michael? Wow. Huh. So, some oohing and eyeing from the panel. So we'll vote by applause or something. Whoever has basically the best trial put forward will win the golden kidney. All right, let's see who's first. Tian,
that's mine.
give us a 30 to 60 second summary, then we'll discuss.
You know, I think in the adjuvant setting, finding the right patient to treat is really the important part. So I would love a future trial where we're selecting on a biomarker post-op and deciding on a negative, thinking about surveillance versus IO alone, versus in a biomarker positive, maybe IO alone versus a VEGF IO, presuming they're all active treatments.
Can I ask questions? What's the biomarker? To be determined?
To be determined.
And you're comfortable doing surveillance, no therapy in a biomarker negative?
The placebo cohorts, I mean, they're all on surveillance.
I'm just asking. Okay. And you want to give VEGF IO and biomarker positive, even though VEGF has been...
There's microscopic disease, and VEGF probably still has activity.
Okay. Others? Comments?
I think it's good because it also has treatment de-escalation in it. So it's a bit like in the bionic trial. If you thought about doing crossover, like looking at recurrence-free survival, and if that's earlier, then they go into the active treatment arm, something like this.
And you've also limited duration to 6 months in your biomarker negative as one of the arms.
Tian, would you want to use HIF rather than VEGF? Would that be something that would be a different kind of question?
No, it's a really interesting question. There's an active ongoing trial in LightSpark 022, which is asking that question, right, of HIF-IO. So in this space, and so we'll have that answer eventually.
Brian, can I very quickly?
Yeah, sure.
On that topic? It's about duration of therapy in Tian on the 6 years, 12 months. Going back to Rana's comment, I was looking Keynote 564. 20% of patients stopped treatment because of toxicity. The number was 33% on the EP-Nivo. We don't know how much was Nivo stopping versus EP stopping. Does it indeed, even adjuvant therapy in GIST or other tumors, that might be the treatment duration may play a role when you have recurrence. Does it matter if you give 6 versus 12 months based on all the above? Does longer therapy potentially explain part of the reason why EP-Nivo is negative, 564 is positive?
I don't know if I think the summary was it could be part of the reason. I kind of doubt it's the whole thing.
Yeah.
It's hard to believe just 6 more months of Nivo would have rescued that trial. I don't know if anybody has a different opinion.
Those T cells are active, right? Once you've given 6 months, those T cells will stay active for another 6 to 9 months. So I don't know that we're stopping their activity. The people who stop, are they on steroids and things? But I think if we're in a future state and we have a good biomarker, then maybe we can do some better patient selection.
Do you think maybe VEGF or HIF in the adjuvant setting maybe doesn't make sense because the biology of rapidly recurrent disease is probably not HIF-driven? Right? Those are the indolent, long endocrine organ type recurrences. So that's my biggest issue with HIF in the adjuvant setting. David?
Well, you did the HIF-IO combo study, the only one that I'm aware of, right?
In the advanced setting, yes.
In the advanced setting. And so what's the evidence that HIF blockade enhances the immune response to the tumor or enhances the effect of Nivo? What's the evidence?
I feel like you're asking me a question you know the answer to.
Yeah.
There's no evidence. It might not.
Correct. Yeah. Right. 0. So, and unfortunately, that study was never published. But, to go into the adjuvant setting without evidence that HIF blockade adds to PD-1 blockade, once again, it might be a good idea, but we have no evidence. Why we're going to,
Yeah.
And this is obviously not criticizing Tian. I'm just saying this larger trial.
Yes.
We should, do this study.
I'd like to point out there's no HIF on
no,
this
I know.
slide.
That was my idea, David. Tian, great job.
Tom, no, wait a second. I'm criticizing Tom.
Oh, that's a lot. That's encouraging.
That's okay.
Yes. I didn't want people to think I was criticizing.
Of course. Tian, strong start for the golden kidney. All right, David, you're up.
So I already described this trial earlier, just essentially repeating the melanoma study in a selected group of patients. I think, to Tian's point, I don't think we know exactly how to select, but we have some clues of patients who are more likely to benefit based on the studies we've done. So, enroll patients not based on stage, but based on these enrichment criteria. Give half of them pre-surgical pembrolizumab, the other half just post, and see what happens. And it's as good of an idea as any because we actually have randomized data in several tumor types that it's a good idea.
I think you're trying to influence the vote there, David.
No, I'm just not.
Yes, Shilpa. I don't know where the cube is.
I have a question about the stage. So you are proposing patients with stage 1B plus something should be offered adjuvant therapy?
Correct.
When we saw the data with stage 2 and we discussed that maybe the stage 2 diluted the effect of EP-Nivo. Just curious.
Well, right. I think patients with in my opinion, PD-1 only works if you have an immune response to your tumor before you give it. So these criteria that I picked there are enriched for patients who are more likely to have a tumor-related immune response before treatment. That to me is more important than the actual size of the tumor. So, go where if you don't have immune cells in your tumor ahead of treatment, PD-1 doesn't do anything.
Yeah, that's right.
All right, good job, David. This is Axel.
Yeah, I was starting, it's a bit like what David had in mind, but I was a bit more hesitant whether it would be time for a phase 3 at the moment. So this would be randomized phase 2. A bit like what they're doing in melanoma, that you actually decide about treatment de-escalation. So you have, thing is you need clinical TNM, but we have experience from NeoAvax how to do that. And then you would randomize 1-to-1, 40 patients per arm. The neoadjuvant arm would be a Simon 2-stage design where you would test the hypothesis because we have biomarkers, but they're not validated yet. So you treat 6 weeks with ipi/nivo or pembrolizumab. You can, but I would say you have to hit the tumor hard. Then you do your nephrectomy, and based on the pathological response, which is defined according to the melanoma criteria, you decide about whether you continue or not. The theory is that you can at least save 40% of adjuvant therapy once if you've taken your decision. And then secondary endpoint would be disease-free survival and overall survival. If you would already see massive differences there, then you would know you don't have to take this theory to phase 3. But if you wouldn't, then this would be an ideal basis to continue with the phase 3 trial.
Adjuvant pembro with neoadjuvant ipi/nivo just to match the other arm in essence.
Exactly. Yeah. Okay. But then based on the results in your primary tumor, and the pre-treatment should be 6 weeks.
Okay. Thoughts, Tom? You want to say something?
I think that there's something really attractive about this as a sort of a second generation trial. I think one of the questions about whether or not you need to give ipi/nivo neoadjuvantly, and the fact that adjuvantly it hasn't worked, and that's a complicated issue. And I think you'd have to tease out those components. I think the 8x8 trial is going to be important. I think if that's positive, there's going to be a lot of weight behind ipi, and I think it's going to be hard to say it doesn't work, it was active and it's working really well, it's adding stuff. I think if that trial's flatly negative, that's going to be a problem. And so the debate around ipi will be solved relatively soon. At the moment, it looks like the response rate's a little bit higher and the PFS is a little bit longer than you'd expect with nivo alone. But it's not turned out to perform well in this big randomized trial, and that's an issue. The question in this trial is, do we think this is going to cure a whole lot of additional patients that we weren't curing before? And that would be a surprise if it did, to me, because ipi/nivo hasn't been successful in the adjuvant setting, and we've got PROSPER as a neoadjuvant trial, which hasn't worked out that well. Having said that, this is the sort of trial, a randomized phase 2, exactly the sort of trial that we should be doing, because it's a modest size and we can get really interesting biology from this. So I think this is a great trial design. I'd actually like to see a third arm with ipi alone. And the reason why that's the case is then we could do some comparison of tissue of ipi versus ipi/nivo, which I think would be cool.
Yeah, agreed. Okay, last but not least, Dr. Paul.
Yeah, so I have to tell you, when I got the results from Emotional, and I was studying near and dear to my heart, one of the kind of saddest days of my academic career. But I was actually in Greece with Brian and Petros, and we went out for drinks till about 6 in the morning, so I felt better. I felt better by the end of the night. But anyways,
I'm there for you.
But what I would really love to do is really pull a rabbit out of the hat, and I'm really going to use something that was really born out of Tom's genius, which is to really look heavily at biomarkers, in particular ctDNA in this context. It's going to be harder to do in renal cell, and that's why I've left the MRD assay here sort of unspecified. Raina's doing some really nice work with Natera. We have some biomarkers we're looking at with a different company that we're quite excited about for really assessing MRD in this population. But if we can do something very much akin to what Tom has done, taking IMvigor010 to IMvigor011, in bladder, I think that might be a win for us in kidney cancer.